Good afternoon, everybody. I'm glad I'm here. So let's share some knowledge and information on one of the most important and difficult infections, especially for women. So it's important that we manage this condition optimally, because it's also an area where antibiotics are quite misused. So if we look at bacteremia, and in terms of where it's most important, you notice that actually the most deprived people have most infections. And that is actually has been shown to be consistent. So areas which are more deprived, they have more infections. And the bacteremia, in terms of important organisms, you notice that E. coli is number one, and then we have Staph aureus, which usually is associated with skin and soft tissue infections. In terms of resistance, when we're looking at the most important cause of bacteremia, UTI as well, E. coli, you find that the most useful antibiotic, or the most commonly used antibiotic, Coamoxiclav, resistance is very high. And one of the most relied upon alternative after Coamoxiclav is tazocine, piperacillin tazobactam. But you can see nationally, actually, the resistance is also quite high. And then for the others, cephalosporins, etc., it's very high. So that trend is quite worrying, because there are not many other antibiotics left that we can use. And that is repeated in Klebsiella pneumonia, which is also important in terms of UTI and in terms of bacteremia. And if we look at number of antibiotics-related infections by year, you see that E. coli is steady, but maybe going up. And overall, you can see that this is actually quite a worrying trend. And when you look at the resistance, so third generation cephalosporins, when we have resistance to that in gram-negatives, usually this is an ESBL. So you can see it's a quite worrying trend of ESBLs. So UTI is quite impactful on those who experience recurrency. Women who have had UTI, maybe 50% who have another UTI in their lifetime. And actually, you find that these women have quite a recurrent UTI, and it's very difficult to manage. So we don't really fully understand about the recurrence of UTI. That's why we struggle, and the patients also struggle. But there are a lot of issues that we can think of. For instance, we think of UTI probably just as simple cystitis. But we believe in those who have recurrency, there's a biofilm formed in the bladder. And once you treat, the bacteria is sort of cleared, but the biofilm remains. And a few weeks or months later, then the biofilm reactivates and new bacteria starts, and then you got a UTI. And it's quite difficult to treat biofilms, because there's inherent resistance, not phenotypic resistance, but resistance by the nature of the biofilm, because some the biofilm do create things like efflux. When you give antibiotics, the antibiotics are pushed out, and the bacteria which is not multiplying is not affected by antibiotics, because most of the antibiotics we are relying on bacteria to be growing. So if bacteria is not growing, antibiotics usually don't work well. For this reason, we do struggle because we do not have effective antibiofilm antibiotics to use. So the cost for recurrent UTI, or UTI in general, the psychological costs, economical costs, and social costs. So you can see here the number of prescriptions for antibiotics starting from 2017 is the blue bars is quite high, and the cost is the orange line. So it's quite expensive treating UTI. And then, of course, you can see the admissions, which is the blue line. And then you can see admissions increase with age. And also the number of days, if a patient is to be admitted with UTI, the number of days increase as somebody gets older. And it is known that elderly people, if the longer they stay in the hospital, the less likely they're going to leave the hospital alive. Then quality of life. So somebody who actually suffers from recurrent UTI, they're afraid to go in the public. They have to think where the toilet might be, okay? So that is not a good life to have. And then mental health issues, anxiety, stress, depression. They're worried if they go out, how am I going to cope? Will there be a toilet there? So this is quite a heavy cost. Social impact. We have people are embarrassed. They live in isolation. They don't to mix with others. And then, of course, it interferes with their daily activities. So other issues, men, usually we don't expect them to have recurrent, but if they're having problems, either there's a structural problem in the urinary tract infection, or they've got prostatitis. And the prostate is quite hard to reach organ. So we need antibiotics which will go in the prostate. And that has to be married with those antibiotics which are actually effective against that bug. In simple UTI for women, easy to treat, 3 days, except when they've got recurrence, which is a biofilm infection. It's so important that the diagnosis of UTI is made properly, and that starts from the patient, clinical diagnosis of the patient, collection of the sample, and the lab, and the interpretation of the result. So here we have guidelines in terms of when should urine be collected, okay? So patients who may have positive urine because it was sent inappropriately, they have no symptoms, that's asymptomatic bacteria, does not need treatment. So UTI should have clinical symptoms. So if there are no symptoms, you can actually look at what are the other things that might be causing issues with the patient. And then you should also be able to use that flow chart. For instance, when you're doing dipstick, you can see there's a nitrite, leukocyte, and red blood cells positive or positive. Likelihood of UTI is very high. If just one of them, then the likelihood probability reduces. So you have to also consider whether you go forward to treat that time or wait. And of course, if any of the indicators are negative, that's no UTI. So in the first part, we're trying to optimize therapy. So we know the likelihood of UTI is very high, optimize therapy. In the second box, we're trying to optimize diagnosis. So send urine so that we can confirm the diagnosis to avoid unnecessary antibiotics. Sample collection. So we need to have a quality sample. And midstream collection, midstream urine is what we need. The best sample is first thing in the morning. And transportation of this sample, because the patient might store the sample for some days, then the sample is not good. So when we look at the analytical phase, that's also very important. In the laboratory, how is the urine coming in? Is it in the right container? How long has it been there? And then we also look at, for instance, there are times when the lab might be struggling. So the urine might be 4 days old. Is it worth processing it? Of course not, because the result might be unreliable. So we have to tell the patient or the users to say, we have problems, we can't process your urine because the result will be unreliable. So urine samples are one of the highest volumes in any lab anywhere in the world. So for instance, where I work in USCW, we process over 180,000 samples per year, and that's too much for manual handling. So we have to use a machine which helps us. And that machine is can actually see whether there's bacteria in the sample and whether there's any other cells. And on that basis, the sample will be accepted to be processed further or rejected, because it's rejecting because there's no indication that there could be bacteria in that sample. And then when we got results, you can see here we are looking at, I've emphasized epithelial cells. So there are 3 types of epithelial cells. The squamous epithelial cells, these are in the urethra or the vagina. And then transitional cells, these are in the bladder. And that might mean actually there's an irritation or infection in the bladder. But renal tubular cells, that might mean there's a problem with actually the kidneys, which might not actually be infection, but it requires maybe the referral further on. But if you got lots of squamous cells, then poorly collected urine. So a result which comes like that, so it's something has grown, but the poor collection throws some doubt whether this sample actually represents infection. I'm not sure whether you can see, but we use normally our UTI antibiotics. There's fosfomycin, methicillin, nitrofuran, and trimethoprim. So you can see that the yellow line is for trimethoprim. The resistance was very high at one point, and we abandoned that trimethoprim, so we never used it for some years. But then later on, the resistance dropped, and then we reintroduced trimethoprim in the treatment protocol. So these are our guidelines for community, and you can see even we still don't put trimethoprim as first line, is second line, third line, and even there is not at the top. So you get some challenging results. For instance, here we got Pseudomonas. So Pseudomonas is an environmental organism. It should not be causing UTI unless there's something in the urinary system which is not supposed to be there. For instance, a catheter, or maybe somebody has got stones. But otherwise, we do not expect Pseudomonas to be causing UTI. So that result then becomes questionable. So therefore, when urine is being collected, all information should be there to say, this is from catheter, or this is midstream. Then we can do the interpretation to say, no treatment required, this is probably not important, repeat sample, okay? And then post-analytical phase. So again, the results we are sending out to make sure treatment is optimal. For instance, here we've got E. coli. I've highlighted in green the UTI antibiotics that we use. So again, if information is not enough, we don't know whether this urine was collected properly, and sometimes it's collected after dipstick and the woman has no symptoms. So no dipstick because the woman hasn't got any symptoms, and therefore there's no need to send urine. So all that information is required to make a useful report. Now we can also have results like this. So the results like this, you have ciprofloxacin tazocine I. We've already talked about Pseudomonas, assuming in this case it is a genuine pathogen. So when you get I, meaning you have, it is sensitive, but you need increased exposure. So for some antibiotics like beta-lactams, here will be piperacillin tazobactam. Here you just need increased frequency because it's a time-dependent antibiotic, killing antibiotic. With ciprofloxacin, which is more of concentration antibiotic in terms of killing, you just need to increase the dose, not the frequency. So here we use standard dose is 500, but here we would recommend 750 milligrams PT. Tazocine would standard would be 4.5 grams TDS. So here we recommend 4 times a day, the same amount. So in terms of treatment, we've looked at what antibiotics are there, but now we're looking at other possibilities, which actually this is in clinical practice now. Hipurate has been shown to be actually equivalent to nitrofurantoin in terms of preventing recurrent infections. So that we have just introduced that in our primary care, that GPs can use that as an alternative to antibiotics, which again helps to reduce the probability of resistance. We don't have it here, but elsewhere they're using a vaccine. And this vaccine is tailor-made to E. coli, which is the most important UTI-causing organism, and showing quite a good promise. So I know there are some trials in some UK NHS hospitals, but it's not yet licensed here. In terms of the future, we are talking about recurrency of UTI. So biofilm, antibiotics cannot touch biofilms. Normally, if biofilm, if it happens, usually on foreign material like prosthetic material, we have to remove it to treat. So in this case, we can't remove the bladder to treat recurrent UTI. So what we need is phages, which are viruses, which are specific for killing bacteria. So I think this is an approach which can work because in very complex orthopedic conditions, for instance, in France, they will use phages to treat biofilms, where the prosthetic material cannot be removed. They will isolate bacteria. By the way, the phages are very specific for each bacteria. So you have to send in the bacteria, and they have to find the phage that can kill it. So that is probably things that we need to look at. In terms of antibiotics, there's really nothing that promising. The only antibiotic I could find it is gipotedacin, which is just equivalent in terms of outcomes to nitrofurantoin. So there's nothing in the pipeline which will really work against UTI. But remember, I've shown you some of the antibiotics like nitrofurantoin. Resistance is quite low. So it's not really like we are struggling that much for simple UTI antibiotics. But it's the recurrent infections whereby we have no means of tackling those because there's no biofilm. Okay, I'm being told that I should finish, so I'm finishing. Okay, so so UTI is very, very important condition. I'm sure everybody will know somebody who is struggling with UTI, and I get a lot of questions from patients about that. But it's really something that we have to be sure we're collecting properly and doing everything properly. So thank you very much.